Good morning and namaskar, everyone. I am Aryan Manisha Dhaba. I have just completed my Master of Nursing in Critical Care, and today I'm here to discuss on arterial line. In short, we can also call it A line. From this A line, we can do the hemodynamic monitor, but it's an invasive procedure. So, an A line is not just a better to pick off, but it's a lifeline, but only when you understand it. And from today's video, we'll get to learn about this. We'll learn about this. So now let's move on to our topic. So A line. For the A line, we need a small catheter, probably the 20 gauge cannula for the radial artery, and a little more 18 gauge cannula, or the femoral seat for the femoral artery. So, like that, right? We need a small catheter that is inserted into an artery. Usually, preferred artery is an radial artery, and while sometimes we can also use the femoral or the brachial as per the requirement and the convenience. And this small catheter, whenever it's inserted into the artery, is connected to a pressure is connected to a pressurized flush system and a transducers. And here's the magic, that it provides continuous beat to beat blood pressure reading. In every single beat, it gives a continuous blood pressure reading. So why does that matter, and why do we require that? Because in a crashing patient, each beat matters. So we need patient blood pressure reading during a crashing time. So this is A line is definitely a lifeline to provide an accurate blood pressure reading in a critically unstable ill patient. So indications, main indications is for getting the continuous blood pressures monitoring for a patient who is critically ill and unstable. Similarly, from the A line, we can use that blood draw from this A line for the frequent blood sampling for like arterial blood gas, or for other routine examinations. Also, we can use that blood draw samples from where a patient do not require and repeatedly sticking onto the patient vein or artery. So hemodynamic gives a hemodynamic trends from that continuous beat to beat blood pressure reading. So think of it as you have a real time dashboard that gives informations about the patient's circulations. So this is the indications of the A line. Now we'll discuss on the equipment and the setup. A line is only as good as its setup. If any pieces fails, your number lie, and in critical care, a lie can kill a patient. So it requires a definite setup and equipment. Let's see the component for the A line. We require an arterial catheter that is inserted into the artery. Yes, for the radial artery, is preferred cannula size is the 20 gauge cannula, or for the femoral we require 18 gauge cannula, or the femoral seeds are being inserted into the femoral artery for getting the continuous beat to beat reading. And the pressure tubing, the tube we have on the A line is of non-compliant and is filled with saline to get that way pressures, blood pressures way being transmitted exactly what it is because of that non-compliant tubing. So we have a very compliant tubing in our intravenous IV seat, but for the A line we require non-compliant tube, and we require flush device also, and maintain the pressures of 300 millimeters of mercury to maintain the patency, so that the pulsatile blood flow doesn't backflow from this tube. So we need to maintain that pressures, and of course we require the transducers and the monitors. They are crucial part. So the transducer converts the pressure waveform that is coming from that artery, and that convert it into the electrical signals, and in the monitor it is displayed, it is displayed in the form of waveform, and also the numeric blood pressures value along with the mean arterial pressures is being shown on the screen. So these are the equipment and setup. So this is one of the kit of the A line, and this is the transducers. This part here we can use it for the flush, and we can also do the flush test by using this, pulling this flush device. And being a critical care nurse, we need to understand this transducer. Different monitors has different compatible for the different transducer devices. So there is many other devices or the cable or the transducer cable available. So according to that, we need to check that whether this transducers is compatible with our monitors or not. We need to make sure before pulling out this kit from this trial pack, right? So IV cannula, and this is the monitor showing the A-line waveform along with the systolic diastolic blood pressures with the map, and here is the pressure bag. Different kind of pressure bag is also available. So it is one kind where we need to maintain the patency by maintaining the blood pressure back of at 300 millimeters of mercury. And another important thing we need to understand uh, in the A line is the jarring and leveling. It is very crucial for the accurate blood pressures reading. So why we require a jarring? Jarring is required because jarring cancel out all the atmospheric pressures, and therefore shows the accurate blood pressure readings of our artery. So jarring is very important, and this jarring should be done, and also the labeling of the transducer should be placed at flebostatic axis. What is flebostatic axis? Flebostatic axis is a fourth intercostal space in the mid axillary line, crossing it, this fourth intercostal space and the mid axillary line, the intersections here is the flebostatic axis. We need to place our transducer at this level. Why there? Because that's roughly the level of the aortic root. Miss it by a few centimeters, our BP reading shown in the monitor could be off by 5 to 10 millimeters of mercury. And think of the patient being on buzzer pressures. That's not a small error, that's a disaster waiting to happen. So we need to maintain that transducer at the flebostatic axis for these regions, right? So this is the arterial waveform, and you can see here it's a systolic upstroke. Sharp upstroke going upward is a systolic. Sharp upstroke going upward is a systolic, and you have here a beautiful dichrotic notch. Here you can see this dichrotic notch is here, and then there is a slow down slope that denotes the diastolic. And the beauty of this dichrotic notch in the arterial waveform is that it reflects the efficient left ventricular ejections and relaxations. And one of our professors said that of in the arterial waveform, just look whether there is dichrotic notch or not. It is the moment when the heart says, I'm done with pushing, baby, just refill me. This is how the heart says, and this is what we understand by seeing this dichrotic notch. Our heart needs to be filled also. So this is where the transitions happen and we get a dry dichrotic notch in the arterial waveform. Okay. Now let's move on ahead. So another, being a critical care nurse, we need to depend, not only depend on the waveform or the number, we need to really identify whether the waveform shown is accurate, is normal or not. So for that we do a fast flush test, or also called the square wave test. If we pull that pull that flush device, and then there will be an square formed in the monitors. We can see the formation of this square with that flush device, and then remove that flush device, and you see the oscillations. If there is 1 to 2 oscillations, that means your waveform is normal and you can trust the number you are getting there in the screen. So this is normal. You need not to be worried about your numbers. You are ready, or sorry, you can trust your waveform. So this is the normal waveform, normal flash test result. But if you see a lot of ringing or more than 3 oscillations, then it means underdamp. More than 3 oscillations means underdamp. And if there is no oscillations means overdamp. Remember, no oscillations, overdamp. More than 3 oscillations is underdamp. So this is how you can trust your value doing the flash test. If it is 1 to 2, trust your monitor readings. But if it is more than 3 or no oscillations, that are both dangerous, and you need to recognize them in time. So let's see the what are the causes for the underdamp artery system. It could be related with the system or the catheter or the patient, but for most thing you always need to see the patient first before checking all other things, right? So but here we see the causes for the underdamp arterial line. They in system related, it could be due to the excessively very stiff tubing. Of course the tubing need to be non-compliant, but if it is very stiff, then it could lead to a more than 3 oscillations, and it is called underdamp. And a very short tubing to the transducers can also lead to an underdamping, and that is system error. And excessive pressure tubing or hyperdynamic monitoring systems can lead to an underdamp arterial line. Catheter related, if there is a loss of moment, weep, and if the size of cannula is large, then we can get more than 3 oscillations. And in patient related, if the patient has hyperdynamic circulations, as in sepsis, fever, thyrotoxicosis, so at that time also you can get an underdamp arterial line. And how can we fix that? For that we need to maintain or secure the catheter and tubing to an appropriate size, length, and minimize the patient movement, optimize the tubing setup, check the flush device, correlate with non-invasive blood pressure monitoring or the manual blood pressure monitoring with the waveform, and just read the patient. Okay. And what are the causes for overdamped A line? For the overdamp A line, again, there could be a catheter related problem, or the tube or system related problem, or the patient related problem. And in critical care setting especially, we see the overdamp kind of problem on a critical care setting, and just remember that overdam O means there is somewhere obstructions and therefore there is no oscillation seen. Remember the O for overdam and O for obstruction causes. So catheter related causes, there could be somewhere occlusions or obstructions because of air bubbles or blood clot in the catheter, or the tube has been kinked. So this can all result in overdamping, showing no oscillations. And the catheter against the vessels, while they are just against the vessels, was having a partial occlusions, and a small catheter size will also lead to a overdamping. And if there is a loose connections, excessively compliant tubing, a very long tubing on multiple stop cocks, so these can also lead to a no oscillation, that means overdamping of the A line. And in patient related, severe hypertension or the arterial itself is in spasm conditions, then that could also show an overdamping situations or a problem in the flush test. So by doing the fast flush test or a square test, we can identify whether it is normal, overdamped, or underdamped conditions. For the overdamped, nursing management includes flushing the line, removing the air bubbles, checking the tubings for kinks, repositioning the limb or the patient, assessing the insertion site for any sign of infections, and blood clots being present on the insertion site likewise, and perform the square wave test or the fast flush test. And if it doesn't work, then we need to replace the tube or catheter if needed. So for the summary, A line is special things in critical care setting. It provides continuous beat to beat blood pressure reading. We need to zero and label it in a flavor-static axis. We need to ensure whether our waveform is accurate or not by doing the fast flush test, and always treat the patient first based on your assessment, and then troubleshoot the system, because in the end the best monitor in the world is still you. Trust me, your assessment, your knowledge, your efficiency, your practice, your everything makes you a better monitor, best monitor in the world. So trust your assessment, concern with the seniors and doctors, and then move forward with your with what you are looking forward and what you are recording. Make sure your readings are accurate and trust yourself and your assessment. Okay, so yes, that was all about the arterial line that we discussed today. And if you have any queries, please drop down that in the comment box, and we'll see you soon. Thank you so much. Learn, live happy, and stay tuned, stay healthy. Thank you.